Hi, I'm Dr. Brawley Wong. My pronouns are she, her. I'm a board certified family physician and I love gender and reproductive health care. Today, let's talk about trauma informed care and how we use it to mitigate dysphoria in the healthcare setting. This video is not going to be all inclusive, so please share in the comments any ideas or experiences you have with decreasing dysphoria in healthcare. Overall, the transgender and gender diverse community experiences higher rates of trauma than their cisgender peers. Trauma can be to the point of abuse and assault. Additionally, trauma includes chronic stress from having one's identity rejected by family, peers, and society in the form of discrimination and marginalization. These adverse childhood events lead to both worse mental health outcomes and worse physical health outcomes. For this reason, it's important that healthcare providers do everything in their power to avoid re-traumatization and to encourage resilience. Trauma-informed care embraces 6 basic principles. 1, safety, both physical and emotional. 2, trustworthiness and transparency. 3, peer support. 4, collaboration and mutuality. 5, empowerment and choice. And 6, acknowledging cultural, historical, and gender issues. Jennifer Potter, MD, through Fenway Health at Harvard, has a great PowerPoint that details through patient cases how to apply these 6 principles into patient care. I'll include a link to her PowerPoint in the description below. Now, let's go through a typical office visit and apply some of these aspects of trauma-informed care. First, the office and room setup. First and foremost, a medical office should be doing everything in its power to ensure physical safety. Ways to do this include making sure parking lots are well lit, having security cameras, and maybe even security guards. Patients should always have clear access to doors and exits. When setting up the patient room, we should be mindful that the patient and provider can be at eye level with each other. And the provider should be cautious not to block the pathway of the patient to the door. Additionally, we can protect emotional safety by decreasing dysphoria triggers. One example would be to ask staff to call patients by last name, first initial, like Smith H. This avoids misgendering that can occur with honorifics, like Mrs. Smith. It also avoids the emotional distress of calling a person by their dead name. Additionally, waiting rooms should include pamphlets and posters and photographs of diverse people and diverse families to honor and acknowledge the diverse cultural, societal, and gender identities of our patients. Offices can instill trustworthiness and transparency by having consistent protocols and schedules. One of the reasons I love using the Fenway consent form in my gender affirmation practice is because it has a dedicated section where it outlines what the patient can expect from the medical team and what the medical team expects from the patient. Next, the interview. Prior to starting the interview, the healthcare provider should introduce themselves with their name and pronouns and ask what name the patient goes by. For example, "Hi, I'm Dr. Brawley Wong. My pronouns are she, her. What name do you go by?" Displaying your pronouns on your ID badge or on a pin on your coat can also help to create a safe space. Emotional safety is also protected by protecting privacy and not asking questions that are not relevant. For example, if a person comes in for sore throat and a cough, you don't really need to know if they've had gender affirming surgery to treat their symptoms. Additionally, providers should avoid using gendered terms like these that could potentially trigger dysphoria. Trustworthiness and transparency is further built in the interview by explaining why certain questions are being asked and asking permission to talk about body parts and transition status. For example, if I was seeing someone for a yearly physical, I might say something like, I want to make sure that I'm offering you all of the appropriate cancer screens. Is it okay if we talk about body parts so I make sure I'm not missing anything? Additionally, you can empower and collaborate with your patient by asking them what terms they prefer to use for certain body parts. For example, many of my patients prefer chest tissue to the term breast tissue, since in general society, breast tends to be associated with womanness, which can lead to dysphoria and invalidating someone's identity. Other common terms I've seen are using front hole instead of vagina and using testosterone producing tissue instead of testicles. For the physical exam, we follow a similar principle of transparency by explaining the necessity of each physical exam maneuver. Additionally, the physical exam is a great opportunity to practice peer support by offering the patient a chaperone of their choice. Consent is key to maintaining safety during the physical exam. A provider should announce what the next step of the physical exam is, then wait for the patient to acknowledge understanding and consent. Providers should remind patients, especially during invasive exams, that the patient can ask for the exam to be stopped at any point in time. Wording during the physical exam is also important. In addition to using gender-neutral anatomical terms, we should avoid phrases like "for me," such as "take a deep breath for me." Another opportunity to improve wording is during exams or procedures that require stillness. Instead of repetitively commanding, keep still, try offering the patient an alternative outlet for that anxious energy. For example, if you feel the need to move, you can wiggle your toes. By reframing and rephrasing our wording like this, we work to develop a more collaborative relationship rather than a commanding one. Finally, the plan. This is where collaboration, mutuality, empowerment, and choice have the opportunity to shine. The shared decision-making model is paramount. I conceptualize the shared decision-making model by viewing my patient as the expert in their own body and lived experience, whereas I, the healthcare provider, am an expert in scientific and medical studies. In order to create an effective and safe plan, we need to work together to combine our expertise. To ensure safety, I do have to set boundaries that may not always align with my patient's goals. In these scenarios, I first empathize with the patient's situation and then explain my concerns. One phrase that can help patients understand my perspective and my boundaries is the following. My first priority is always your safety, followed very closely by my second priority, your happiness. I love and strive to promote both your happiness and your safety. But if I ever have to choose between the two, I will always put your safety first. Thank you to Dr. Eicher, one of my favorite addiction medicine doctors, for suggesting this topic. I hope this helps providers everywhere improve the care and patient experience. If you enjoyed today's content, please like and consider subscribing. Thank you so much. See you later. Zola.